How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melindy, and this is Disruptive Dialogue. Hey everybody, Chuck Melindy with Disruptive Dialogue. I'm here for the second part of my interview with Roaya Tyson, the CEO of Gracepoint Behavioral Health, soon to be IBIS Healthcare. Roya has been with Gracepoint for over 23 years and started from being a social worker, worked her way all the way up.
At age 5?
At age 5, absolutely. All the way up to CEO. And she's been in that role for 2 years now, 2.5?
2.5.
2.5.
Yep.
And as we said in the first episode, in the middle of a merger.
Yes.
And very excited.
Very excited.
And so we're going to talk about two things today. We talked a lot about mental health and the different type of facilities that treat mental health and the pros and the cons. One of the things that I want to get into a little bit today are two areas. One has to do with a little bit with your merger because, and I'd like for you to expand on this. Gracepoint, that you run right now, is focused on behavioral health. And the other organization, The Cove, which is going to come together with y'all to form IBIS Healthcare, they're focused on substance use disorders.
Correct.
Share with everybody why that's a good thing for a community and why y'all did it.
Well, the reason we did it was most community agencies, so Gracepoint is a community agency and Cove is a community agency, and we all kind of tout that we're co-occurring, which just means that we treat mental health issues or disorders as well as addiction. But really, it's cursory on one side. So we are very heavy into mental wellness, mental illness, and we do a little bit of, substance use treatment. They're the exact opposite. They do a large amount of substance use treatment and a very small, tiny piece of mental health. So we thought, wow, how cool would it be if we were able to have one full continuum of care? So no matter what door you come into the substance use door, and we say, oh no, you got some depressive issues going on here, that you can get that taken care of as well as your high blood pressure. So no matter what door you come in, you're going to get what you need. And it just kind of made it more seamless than having all this fragmented silos kind of thing.
Right.
Yeah.
And I would think sometimes, not all the time, but mental illness and substance use disorder might go hand in hand.
Oh, 100%. Usually it's a chicken or egg type of thing. Did I have the depression and then I started self-medicating, or was I self-medicating because I started taking opioids after surgery and now I'm depressed because I can't get off it and I've lost my job? So, it's really, they go hand in hand more often than not.
So I'm going to throw you a curveball.
Of course you are.
So, hospitals.
Yeah.
And most people, everybody knows what a hospital is.
They
They're everywhere.
They are.
And they serve a fantastic place in our society.
Absolutely.
They're amazing. I have a ton of good friends that work for hospitals, et cetera.
As do I.
Now, that being said, a lot of people don't know what CHCs, community health centers, or community mental health centers, what those are. What is the advantage of going to a community mental health center for a mental illness or substance use disorder versus a hospital? And I will caveat that with hospitals are phenomenal with their emergency department, surgeries, inpatient with, all kinds of physical illnesses.
Yes.
They have a purpose.
Yes.
Do you think that patients would get as good of treatment, or they are the best place for them to go compared to a community mental health center, which y'all are focused on that area versus all these different areas? What's your opinion?
Okay, so this is just my opinion.
Of course.
I absolutely agree with you. Hospitals are a critical component of our health system.
Of course.
It's just a no-brainer. But if I was, this is just me now.
Sure.
If I was diagnosed with cancer, God forbid, I'm probably going to go to a hospital that specializes in cancer.
Sure, an oncology clinic,
Moffitt, right.
MD Anderson.
I'm not going to go probably to a hospital that dabbles in 62 different specialties. Not that there's anything wrong with that. Sometimes, if you're a rural community, that's all you have. But if you have an opportunity to go to a place that specializes in the issue that you're facing, why not do that? And so that's kind of what a community health agency does. Their focus is solely on behavioral health and primary care integrated, which usually goes very hand in hand.
Yep.
That's not to say that hospital systems that have broken off and have behavioral health systems aren't good.
Right.
My point is that I think it's a little bit diluted because the leadership and all that good stuff, their attention is spread in 52 different areas.
Of course.
And so they're not going to give it the attention that we would give because this is all we're focusing on. And so I use Moffitt as a good analogy. And the other part of it is that some of these behavioral health hospitals, for-profits and nonprofits, partner with a for-profit entity to manage. And so that's also a very different business model than what a true for-profit would do.
Expand on that for me.
So, if you're working in a for-profit setting, you are beholden to shareholders, right? I mean, that's where the margin goes is back to the shareholders because
you're talking publicly traded.
I am.
Okay.
And so a lot of and I'm talking across the nation, I'm not talking about just Florida, but a lot of them will partner with a for-profit behavioral health chain, if you will.
Okay.
And they'll say, oh, we can set up, you build the hospital and we'll manage it and we'll set up. And so then the in my opinion, the focus then is mostly on margin and what our numbers are going to be for the shareholders versus we're going to take this money, we're going to put it back into the agency and to the raises and to the medications and whatever else that we need to make this the best facility we can make it.
So I will take a little of the heat for you.
Please.
So first off, it wasn't to disparage hospitals.
Of course not.
Like we can't survive as communities without hospitals. But master of, jack of all trades, master of none?
Yes.
Hospitals, to your point, have so many different services.
Correct.
They help and support our community in so many different ways.
Correct.
But your analogy with if you have cancer, if you have an oncology practice or like we have Florida cancer specialists here in the state of Florida, or you have a Moffitt Cancer or MD Anderson, these different facilities that specialize in oncology.
Yes.
That's where most people are going to want to go.
I would think so.
If you have a mental health disorder or a substance use disorder, if it's me, I would want to go where that is all they focus on.
Correct. Me too.
Which is the CMHCs, the CHCs. It doesn't mean that the hospital cannot take care of them.
Of course.
Of course they can take care of them. They're going to have a psychiatrist there. They're going to have therapists there. They're going to have all these things.
Yeah.
But if we're going to treat mental health with the same priority and urgency as physical health, well, in physical health, if you're going to go to a specialist for a knee replacement or a cath for your heart, why wouldn't you do that for mental health?
That's exactly
and so,
what I think.
I'm doing a prop for community mental health centers because I think that they're vital to our community where we have them. If we don't have them, then absolutely you can get some great care at hospitals.
Of course you can.
It's just not as specialized.
That's exactly what I'm
that
trying
fair?
to say. That's very fair.
Okay. Now, I'm going to jump on one other piece, which is the for-profit. So there is a difference between not-for-profit, for-profit, and publicly traded companies. Publicly traded companies, I will say it again, I do not think that they should be in the healthcare business as far as providing services. At the end of the day, and I've railed on the insurance companies and PBMs and the people that work for them, great people, they have their job, they do their job, but they are beholden and their fiduciary duty and responsibility is to their shareholders, not to the patients.
100%.
That being said, a not-for-profit or a for-profit entity that is not publicly traded probably has a lot more focus on the patient and more of a fiduciary duty. And then I would say you could then go to the not-for-profit and say they're probably more focused on the patient and the service than the for-profit.
Right.
Because they're dumping all their money back into their services.
That's exactly right.
They're not, creating these endowment funds and all this kind of stuff.
That's exactly right.
So
well said. Thank you.
once again, not trying to disparage these
Not at
other
all.
facilities and entities. I just think that, look, you know what? You got to call a spade, and you want to go where the people are focused.
Well, I think people need to know what the difference is and know what they're getting when they walk in the door. And then it's their choice. I mean, that's really what this is about, too, is choice.
Absolutely.
And so I believe in transparency. And so know what you're getting when you walk in the door.
And I've heard I'm kind of transparent. I actually talked to someone the other day, and they said, I listen to your podcast. You're brutal. You don't hold back any punches. I'm like, yeah, that's why I left the corporate world so I could do that. Yeah. So I do want to bring up real quick before we get into a topic called mental health parity.
Okay.
Before we do that, I saw a really cool study.
All right.
And because your organization is coming together with the substance use disorder organization, the COVE, to form IBIS Healthcare, this was a crazy story that came out of Axios Vitals. So I think everybody knows, and if you go to my website or you listen to this, I do my best to research what I'm going to talk about. I post on Facebook and LinkedIn almost every day.
Yes, I know. I see it.
And I'm pulling stuff from the Wall Street Journal, from Avalier, from Drug Channels, from Endpoints, from Healthcare Uncovered with Wendell Pot, all these different things. The cost of opioid addiction in our country is mind-boggling. So I'm reading this, and I'm just going to read this because I just saw this today. Okay. Opioid abuse is as much an economic problem as a public health problem. According to a comprehensive analysis provided by Axios, it concluded the average cost is nearly $700,000 to treat an affected person who has been abusing opioids.
Doesn't surprise me.
$700,000, and it varies by area of the country. So,
but does it outline what that $700,000 is? Is it just health?
Yes.
Is it legal stuff? Is it theft?
Yes. So it talks about everything from lost wages, lost tax revenues by state.
Makes sense.
The treatment, the
incarceration,
the repeat of those things.
Mm-hmm.
You know, you have maybe someone who has been working and very productive, paying tax. Now they are not. Now they are a burden on the system. Mm-hmm. They are getting treatment by professionals. They are getting, treated with therapies that are not inexpensive. So those numbers are huge, and they range from anywhere from, like I think it said in Idaho is like $419,000 per case. In DC, over $2 million per case.
Wow.
Yeah. So, I just look at this, and it wrapped it up by saying the opioid use disorder costs the U.S. projected in 2024 $4 trillion with a T.
Wow.
$4 trillion. To me, that is mind-boggling. And we talked in our previous episode that this is an epidemic. Mm-hmm. And we want to treat this epidemic because it's people we love and we care for, and they're our fellow human beings. But it's also an economic issue.
Big time.
And so one of the things that you and I have talked about, because we deal as, we are a not-for-profit. Mm-hmm. And so we are going to the state and the feds all the time, basically begging for money.
Yes.
Begging. That's the proper term.
That's the word.
And, at the end of the day, to be able to treat these people, not only to treat them, but prevention ahead of time and possibly prevention after they've recovered, we need to put our resources to it. A study found that 1 in 4 Americans in frequent mental distress could not see a doctor in the U.S. due to cost. 1 in 4. Mm-hmm. And so I know in 2008, a law was passed around mental health parity. Mm-hmm. I'm going to give it a quick dummy version, and then you can expand on it. But my understanding is basically it was the government telling insurers, you have to pay or reimburse for mental health services at the same level as physical services.
Sounds good, doesn't it?
It sounds, that'd be ideal.
Sounds nice.
And great.
Yeah.
Is that correct? Is that what
that's
the law?
Correct. That's what it says.
Generally,
that's exactly what it says.
Yeah, like saying, okay.
They need to be equal.
Okay, need to be equal.
Yeah.
But in the previous episode, you said that a physical therapist makes a hell of a lot more than a
mental health therapist.
Mental health therapist.
Sure.
So we're not really seeing that come to fruition. And that was back in 2008.
Correct.
Okay. Now, the other piece, the other law, was the Affordable Care Act. And the Affordable Care Act basically said that health plans had to treat patients with mental health.
Right.
Or mental illness, excuse me.
Right.
They were not required to do that prior to the Affordable Care Act, from what I read. Is that correct?
Yes.
That's crazy.
Yes.
So health insurance companies, prior to the ACA, were not required to provide mental health services.
That's correct.
And then, 2 or 3 years before that was the Mental Health Parity Act,
right?
And that was
the catalyst to make things better, to right the wrong.
And so the news recently is that there's 3 agencies, and HHS is one of them, is going to relax the enforcement.
Wow. Well, there was no enforcement to give us, so what would it matter?
Okay, so talk to me about that, Roaya.
I'll talk to you about that.
Yes, please.
So I can give you let's not even start with what is and isn't covered. Let's just say the reimbursement rates are so inequitable. It really devalues what, for instance, a psychiatrist or a mental health clinician does. There is not nearly as much value to, let's just say, we take care of a woman who has postpartum depression and she's unable to get out of bed and isn't, taking care of herself, and et cetera, et cetera. And our ability to bring her back to her happy self, where she's enjoying life, enjoying her family, taking care of things, is not as valuable as somebody coming in and getting their broken wrist fixed for some reason. That's one has much more value over the other. Parity is not just about what is covered and what isn't. It's also about the amount that's covered. And it's also about, I'll give you an example. It's probably the best way to do it. We have a primary care clinic, and it's federally funded, if you will. Not even really funded. It's governed. That's a better, licensed by the Fed. So it's called a Federally Qualified Health Center, and we're a lookalike, which means that we don't have access to all the grants and stuff that regular health centers do. So we were billing our primary care services. Someone's got a cold, we bill it. Somebody comes in for a behavioral health assessment, we bill it. Well, the clinic is supposed to do what's called a wraparound payment. So say we charge $50, but the real cost is $100. They're supposed to give us the other $50 to cover our costs. They will do that. Medicaid will do that for a physical health visit. But if you get a mental health assessment done or go in to see the psychiatrist for your depression, they will not pay that wraparound dollar to make you whole. Now, you tell me where the parity is.
So wait a second.
Yeah.
So now, let's real quick.
Yeah.
Medicaid differs by state.
It does.
So it is state run. So this is the state of Florida.
Florida.
This could vary.
Thank you for the clarification.
In other states. So
Correct.
This is not a federal thing.
This is a state.
But this is an example.
Where
if the cost for, we're just going to use a broken wrist.
Sure.
To fix it is $100.
Yes.
Or someone comes in with an episode and is going to be treated for a mental health episode, $100. Mm-hmm. If you only get reimbursed $50 for the broken wrist, the Medicaid system will reimburse you the other $50 to make you whole to cover the cost of that service.
Correct. That's right.
But on the mental health side, if you're paid $50, let's say by the patient, but that's $100 as well, the total cost, they don't.
Oh, well, exactly.
And is there a reason or a rationale for it?
I wish I knew.
Seriously, this is crazy.
It is crazy. They just don't. We just don't. That's what you get. We don't. That's not covered. Why? Well, it just isn't. Okay. Help me understand that. Why is this less important? And you can't kill the messenger. I mean, they're just doing it. But somebody has made this decision along the way, and it doesn't make any sense to me. So having your office visit, that's not going to get covered. So instead, I'm going to go to the emergency department in a manic state and be treated by an emergency room physician for God knows how much. That you're going to have to pay for.
So let me help Roy out here with a broader context, and that is these days we're hearing, with the new administration. And look, to be quite honest with you, I am glad that somebody is really trying to cut our deficit.
No question.
It is crazy how much federally, I always say in the state of Florida, and we don't do everything right, and we just talked about the Medicaid situation, we have to balance our budget.
Of course we do.
It's the law.
Of course we do.
Why isn't that the case in the federal government? So everybody can get mad that something's getting cut. But at the end of the day, we do need to start to be fiscally responsible and not keep spending on a federal level. That being said, to start to cut out things around mental health where it's already in a deficit.
But it's always been the low-hanging fruit. It's like penny wise, pound foolish. Mental health has always been the low-hanging fruit.
But here's the challenge. And, I don't know if whether it's media, legislators, you name it, to your point, to not pay up front to have your mental health providers reimbursed and paid a solid wage that actually attracts them to this field where there is a huge need and a deficit of providers, and that if they're not available, you have people that are going to go to the emergency room where it costs 5, 10, 15 times more and not going to get as good of help because it's an emergency room. They're dealing with all kinds of illnesses and stuff. We have to learn how to prioritize. And, you said it earlier, the chicken and the egg. I mean, my God. Yeah. There's a great story. I love this story.
Okay.
When I first got into managed care, I went to this conference, and this guy was George Bush Sr.'s, one of his surgeon generals, or I don't know, maybe it was even HH secretary, I don't know, but he was the speaker. And he said, I love this story, and I'm going to butcher it a little bit, but I'm going to do my best.
All right, go for it.
And he said, you know what? We were standing on this bridge, and we see this body floating down the river.
Okay.
And so we run down, and we pull it out, and the person was dead. And we look up, and another body is floating down the river. So we're like, oh my God. Well, that person was alive. So we started trying to help him. Well, bodies kept floating down the river. So we got people, we put up a big tent and we started bringing services. And as these bodies came down the river, we kept taking care of these people to the point where the city's like, oh my God, the town is like, we got to build like a hospital or a clinic. So they build it for these bodies that are coming down the river. And someone finally turned around and goes, shouldn't we go up the river?
Hey.
And see what's causing this?
What's causing the
And this guy told me this story, and it's a great analogy, but I'm just like, this is what we're doing now.
This is exactly what we're doing.
It's the ER.
Exactly. It's the catch-all for everything.
It's crazy. Yeah. And look, one of my good buddies, fraternity brothers, was an ER physician for a long time. I mean, just watch that show, The Pit. I can't watch it anymore because it depresses me. That's what really happens. The practitioner's like, that's what really happens. We've got to figure this out in this country, how we take better care of our people before they have to go to the emergency room. And that gets all around that accessibility to be able to go to a clinician who can spend a little bit of time with you. We have got to prioritize these things. And I don't know what the starting point is.
Well, gosh, that's a good point. I'm not sure where the starting point is either. I look at some of the psychiatrists that we've had, and they've gone into private practice, and they're cash only.
Yeah.
They're cash only because they don't want to dink around with the denials and the record keeping isn't exactly how we want it to be, and the medical necessity isn't worded exactly right, and this looks like placement, and it just goes on and on and on. And I absolutely get managed care. I totally get the premise of it. But when it goes so far as to deny somebody care, so that providers that are so hard to come by are now going into private practice and doing cash only at $300 a clip, a lot of people can't afford that. So then what they'll do is they'll go to their PCP, not hitting on PCPs because they are valuable practitioners. But if I had heart disease, I'm going to go to a cardiologist. I'm not going to go to a PCP. And so the same thing is true for a behavioral health issue. I'm going to go to an individual that has been educated in all the different behavioral health issues and be able to handle that in all the most progressive ways possible.
So you brought something up.
I did.
You don't know this question is coming.
I don't.
You brought up primary care physicians. So I was at a conference and I heard that the new front line of mental health treatment is primary care physicians and ER department.
That's absolutely true.
And they are not trained.
They are not. And they tell you they're not trained in it.
Oh, no. And they were some of the people standing up and going, we have these people coming in.
Yeah.
We were not trained to handle this.
Yeah.
They have nowhere else to go.
That's right.
So do you think a potential Band-Aid is maybe in medical school or residency for ER docs and PCPs that they start to get some mental health training?
It should be a core
Not learn on
part.
the job?
It's a core part of the curriculum. That's if I were queen, that's what I would do. It would be a core part of it. Just basic.
Oh, you're a queen.
I am queen, but queen of everything. I'd love to be queen of everything. So I would say, have a basic course on identifying addiction, a basic course on identifying just the A, B's, and C's of what the general population is experiencing. So you can identify it and then refer them or handhold them to the next phase so they can get what they need, just like you would any other specialty.
I may have to call this the Epiphany podcast.
Okay.
I think we just solved a big thing.
I think we did.
No, think about it. If they changed curriculum in medical schools, and it wasn't just because, I don't know if everybody knows this, tell me if I'm wrong, but I think unless you're going to go into the mental health field, you're not being trained on mental health.
It's a very superficial coverage. There's nothing that is in depth as what I am suggesting that they get.
Yeah, I mean, literally to your point, to just teach these residents and fellows going into primary care and into emergency medicine how to properly diagnose the signs, the symptoms.
And know what to do.
And at least be a triage.
Yes.
To get them to a specialist if needed.
That's correct.
But a lot of times it's not
No, they might do a little cursory little survey that's got 3 questions on it, and they don't even look at it because obviously they don't have time. They're trying to get one patient after the other. I mean, that's their livelihood.
My hope is that the schools are doing this and that with this lack of psychiatrists and mental health therapists that they are starting to train it because, like I said, I was at a conference and I read some studies about this. Hopefully that is a path that we're going to go down. So we've touched on the cost of substance use disorders. We've touched on mental health parity. I've infuriated some hospital systems.
I'm sure I did too. Didn't mean to, sorry. Wasn't my intent.
No, it's not. It was more elevating community health centers that most people don't know about to let people know that there is areas that are not just psychiatrists in private practice. There are actually facilities that focus on this stuff.
Yes.
A lot of people don't know this. Hell, I didn't know this 5 years ago. Yep. But I think that we covered off on a lot in these 2 episodes. I want to once again congratulate you on the upcoming merger. It's the Tampa Bay area is very fortunate to have y'all there. I also want to give a shout out. This CEO of 2.5 years.
What are you going to say?
Not only a merger, but they are in the middle of building the first women's psychiatric hospital in the state of Florida.
Yeah.
And I think there's less than a dozen in the entire country.
There is.
That are just focused on women.
This is for women, by women. And it's a safe environment, physical, emotional, and psychological safe environment for women that have been affected by trauma.
Well, if anybody should be paying for this podcast episodes, it should be IBIS Healthcare.
That's right.
But they're not going to. So I want to thank you once again.
Thank you for having me.
Thank you for everyone on your team. Thank you for everyone in every type of medical facility that are taking care of these patients.
And thank you for serving on our board. It's a voluntary board, and you do that out of your heart, so I appreciate that.
You're very welcome. It's my pleasure. Everyone, once again, go to the website, disruptivedialogue.org. Advocate. Don't just get mad. Get educated and do something about it. See you later.